Hello, and welcome to our webcast. I'm Amy Pendergrass with Moss Adams, and I'm going to get us started for today's session, 2021 OPPS Rule, Future Implications of CMS Reimbursement. Before we begin, I am going to play a brief video.
Welcome, and thanks for joining us. We're pleased to present another in our ongoing series of continuing professional education webcasts to help companies and individuals conquer challenges as they plan for what's next. Our presentation will start in a few moments. Before we begin, here are a few things to keep in mind. You can customize how you both view our presentation and interact with the presenter. For better viewing, close all other applications and turn up your speaker volume. You can also adjust window size and placement or enter full screen mode using the controls at the top of the window or dragging the bottom right-hand corner to resize. At the bottom of your screen, you'll see a series of icons, each relating to a different aspect of our session. You can download the group attendance sheet and a PDF copy of today's slides from the slide deck and handouts widget to the right of the slide view. You can ask our presenter questions during the webcast by typing a question in the Q&A window below the slide view and clicking Submit. We'll do our best to answer all questions during the presentation or follow up via email. If you experience technical difficulty during today's presentation, refresh your browser by hitting the F.
Today's webcast is eligible for 1.5 CPE credits. Per the National Association of State Boards of Accountancy, to qualify for these credits, you must attend for a minimum of 75 minutes and respond to at least 5 of the 6 polling questions. The presentation you're about to see isn't legal, investment, or accounting advice. We encourage you to seek the counsel of a professional service provider to apply this content to your specific circumstances. And now that we got all of that out of the way, we have a great lineup of speakers here with us today. We have Valerie Rinkle, President of Valorize Consulting LLC, Larry Vernaglia, Partner and Industry Teams Department Chair at Foley and Lardner, and Paul Holden, Partner and Co-Leader of Provider Reimbursement Enterprise Service in our Healthcare Consulting Group at Moss Adams. And now I would like to turn the floor over to Larry to get us started.
Thank you, Amy, and a special thank you to my friends at Moss Adams for pulling together this important program, and all of you for spending your morning or afternoon with us today. I'm Larry Vernaglia from Foley and Lardner, and Paul and Valerie and I are going to spend the next 90 minutes with you talking about the 2021 OPPS, Outpatient Prospective Payment System, final rule, which was published by the Centers for Medicare and Medicaid Services on December 2nd. It's 1,312 pages, so I'm sure you've all gotten through it by now and have figured out that there are, in addition to the usual update to payment rates, a number of important policy changes that CMS is hoping that the industry will embrace, including maintenance of some payment cuts for 340B drugs, expanding the list of outpatient services that are going to be subject to prior auth, eliminating the inpatient-only list over a period of years, some changes to the hospital star rating methodology, changes to physician-owned hospital policy, and some new COVID-19 data pre-reporting rules. We're not going to cover all of those items, although I will refer you to a detailed appendix at the end of our slides for items that we will not cover. Our goal today is going to be to discuss the rule and policy with a particular effort of forward-looking key outpatient hospital issues, in addition to some of the more common answers that you'll see in the trade press. We'll also address some complicated laboratory issues, remote services, some transplant issues, and hope that you'll have some time through the Q&A feature in the program here to ask questions along the way. We'll try to field them as we go. So with that introduction, let me turn it back over to Amy for a first polling question of the day. Amy?
All right, so we're going to do our first polling question to figure out our audience that's with us today, and that is, what is your organizational structure or type? A, hospital health system, B, skilled nursing, inpatient psychiatric, inpatient rehab, or C, home health, hospice, D, physician group, or E, other. And we will give you a few moments to respond. To participate, please click the button next to the answer you choose and hit submit. And it looks like most everyone has had a chance to respond. So here are the results.
Oh, I owe you $10, Paul. You always win this one.
Sounds like we've got the right people on the call.
Yes, indeed. So why don't we jump right in, and since we do have the right people on the call, mostly coming from the hospital and health system environment, why not get started? And turn it over to Valerie, and walk us through this orientation to looking at Medicare and outpatient services in particular.
Okay, great. Thanks, Larry. So one of the things with regard to all of the topics and issues in the rule and how complex it is, you know, the concept is keep it simple, right? And so let's go back to basics and talk about the order of operations for healthcare insurance, because putting some of these changes in that context, I think, will be helpful. So for all insurance in the United States for healthcare insurance, you have to start with eligibility, right? What payer is the patient eligible under? Does that payer acknowledge this patient as a member or an enrollee with them? And then if there's more than one insurance, there's coordination of benefits to consider. Once you know which insurance they're eligible for, then there's a particular benefit structure or plan. The coverage of that plan is what's key to understand. And often and increasingly, and in the future, I think this is going to continue to be a change, is the setting of care is dictated by the coverage of the benefit. So we're not going to cover this in an outpatient hospital anymore. If you have a freestanding center available in your community or an ASC available in your community, we're only cover it there, not in the hospital setting. Then they add additional requirements such as prior auth, but remember that's provisional. At the end of the day, they can look at the final record and make sure it meets all of the coverage and medical necessity criteria. And then Medicare has a few services for which they publish either national coverage determinations, which set a standard across the country, or they enable the MACs to establish local coverage determinations. But by and far, the vast majority of Medicare coverage decisions are made by the MACs on a claim-by-claim basis. You perform the service. If it's a hospital service, the clinician has ordered the service for the patient. You bill for it. You expect to get payment because by virtue of the physician ordering it, because they're the arbiters of whether it's medically necessary for the patient or not, you typically assume coverage. That assumption is not something that's going to pan out well for you, and we'll talk more about that. And then finally, we get to what we usually spend so much time talking about, the documentation, the charge capture, the coding, the billing, and finally the payment. All those things can only happen after these first two steps. And so it's really important to put some of these changes in that context as I've said. So what's the first major change related to this coverage issue? Well, CMS has proposed and finalized phasing out the outpatient prospective payment system inpatient-only procedure list. What does this mean? This means they're starting with 2021, where they eliminated about 300 orthopedic procedures from the list, and then they're going to take the remaining procedures and phase out over the next 2 years. That means they have to assign all those procedures to APC payment rates going into the future, likely to be comprehensive APC payment rates. One way to think about comprehensive APC payment rates is to think about it as a, quote, mini DRG, unquote. It pays one payment rate for everything on that claim. Hence, it's very important to understand that for most outpatient services, you only bill a single outpatient claim for everything on a single date of service, unless you have a continuous encounter like a patient receiving observation services that goes overnight. You don't take preoperative testing 2 days before ambulatory surgery and put them all together on the same claim. that reduces your payment unnecessarily and inappropriately. You bill one claim per data service, and the CAPC, for some of these larger procedural services, pays you for everything on the date of surgery, for example, one payment rate. So we're talking about 1,700 services that they're going to be phasing out. What does this mean in terms of coverage? Is it Part A? Is it Part B? Because remember, these were mandatorily covered under Part A list. CMS goes through a lot of text explaining that this does not mean that they expect all these procedures to be done on an outpatient basis. Far from it. They just want to leave this back to the physician's clinical judgment, right? Do they meet the 2-midnight rule? And man, this requires you to understand the 2-midnight rule, versus if you don't anticipate 2 nights of hospital care or extraordinary need for 1 night inpatient hospital care, then they can start the order out for an outpatient service. And then if it turns out that the patient needs 2 nights of hospital care, they can always do an inpatient admission order, including an inpatient admission order on the day of discharge. That's still okay too. So you really do need to understand the 2-midnight rule, and you need to prepare for this. Now, this at first, you're going to be maybe thinking, what does this mean to my bottom line if I potentially have a proportion of cases that I'm going to lose Part A payment for? But remember, some of you may be keeping people overnight that don't necessarily need to be overnight because they are capable of being discharged same day. And you don't need to plan or use that bed, and it may make it available for another type of patient. Now, of course, this is in the traditional non-pandemic world. You may need that bed for a coronavirus patient, unfortunately, now in the world that we're living in today. So what about, the terrible QIO 2-midnight review where you are going to keep admitting these as inpatients? The doctor says, yeah, they anticipate 2 nights stay, but the patient stayed 1 night or just barely 2 nights, and the QIO audits it and they deny it. Well, they did this policy, they made it an indefinite, what they call an indefinite exception of putting these procedures that have been removed from the inpatient-only list as of January 1st under the QIO denial. Now, the QIOs can still review the cases, and determine whether they want to educate you about why or why not it meets the 2-midnight rule. Your UR department may still do a review to determine whether you self-deny under the Part B only rule. That's a choice that you can choose to make if the patient only stayed 1 night in the hospital. But please don't use the proprietary rules about intensity of service, severity of illness, because that is not anywhere having to do with the 2-midnight rule. It's a time rule, and do they need time in the hospital? That's what the 2-midnight rule is. But these services have been excluded until at some distant point in the future, any one of these procedures are performed more than half of the time on an outpatient basis. And that's going to be very, very far in the future. But the great news is if for some reason they were performed on an outpatient, you're going to now get what should be appropriate outpatient payment rather than outright denial. All right, with that, Amy, I think we have a polling question.
All right, thank you, Valerie. So our second polling question is, would you say your hospital continues to have blank Medicare outpatient observation cases that are longer than 48 hours? And so the options are below to fill in that blank. So select the one you choose and hit submit. And I would also like to take this time to remind you to submit your questions for the presenters in the Q&A window. If we don't have time to respond during the webcast, we will do our best to follow up with you afterwards. And we will leave this up on the screen to give everyone a chance to submit their answer for CPE.
Paul, what did we bet for this one?
This will be very interesting.
This will be very interesting, and I'm hoping to get a sense of how well people understand the 2-midnight rule with this. I'm looking forward to seeing what the answers are. It's a very not understood rule. And operationalizing it can be challenging as well.
All right, well, here are the results.
Yep, a large part of the audience doesn't know, but some, well, that's unfortunate. Go look if you don't know, if you're in the health system, because this is an important question. And I absolutely think that an actual problem in the U.S. is that true non-covered hospital care or custodial care issues are being masked or under contractual allowances for long outpatient observation stays. And so finance has no idea, I think, about how much of your bed days are being given away for true non-covered custodial care. Now, that doesn't mean it's not appropriate to care for these patients because of the community need, but wouldn't you like to know, because that would give you the information to know whether you need to make different choices about use of your resources. And it's blinded to you because it's typically just written off as a contractual allowance. All right.
Leaving aside for the moment the challenges of SNFs not accepting our patients for all kinds of reasons, like expensive covered drugs and things like that, as well as the challenge of psych patients boarding when we can't get a psych admission. Two things that are no doubt on the minds of many of the folks on the call.
Exactly.
Yeah.
All right. So
and Valerie, I'll take that. Okay. Yeah, absolutely. Just one quick item for folks on the call. With Don't Know NA being an interesting answer, make sure that on a reimbursement, from a reimbursement perspective, that your finance and revenue cycle and other team members are looking at items like your revenue and usage reports, and for those observation cases, understanding how those charges and units are going on the bill. That's very important come cost report time when you're developing those equivalent days and understanding what the reimbursement impact is for imputed days of OBS versus heads and beds for acute and other services.
Absolutely. Thank you, guys. So the next coverage issue is prior auth. The volume of these types of procedures this year have probably been very suppressed due to the pandemic. But last July, CMS implemented prior authorization, but only for outpatient hospital services. And they did it in 5 areas that I think were intentional because people would kind of shrug their shoulders. A lot of hospitals may not perform some of these cosmetic type procedures. And if it's medically necessary, they feel it's going to be very easy to justify. So for those of you who are not so familiar with the medical terminology, blepharoplasty is fixing a drooping eyelid. Botox injections when it's medically necessary. It's for migraines. When it's not, it's for wrinkles on the face, right? Paniculectomy is removing excess skin. Rhinoplasty is a nose job. And then vein ablation is removing varicose veins, okay? So these are what you call quasi-cosmetic procedures. They can be performed for cosmetic purposes, which makes them non-covered, non-medically necessary, or they can be very medically necessary. And CMS started the nationwide prior authorization program with these 5 categories of services. As I said, it started July 1st. They chose not to postpone or delay this policy this last summer. What the process is that hospitals have to gather the data from the physician that wants to schedule this procedure with a Medicare patient at the hospital, and then that data is what they submit to the MAC to obtain provisional approval. For most of these procedures, they're rarely needed as an emergency other than possibly rhinoplasty, right? Rhinoplasty can be an emergency if there's a trauma or fall or something like that, and I think some of the MACs have had to put some processes in place to deal with that. If it's a delay would jeopardize health, life, or function, then there can be a 2-day turnaround, but typically it's a 10-day turnaround. So they're expanding this, very much expected. So this coming July 1st, they're going to add cervical fusion with disc removal, as well as implanted spinal neurostimulators to the list. And I expect we're going to continue to see over time the expansion of procedures added to the mandatory prior authorization program, but only for outpatient hospitals. So why do I emphasize that? Because many of these procedures can be performed in freestanding ASCs. Only maybe Botox injections in doctor's offices, possibly eyelid in doctor's offices, but for the most part, these have to be in a surgical setting. So if a physician's office that has privileges with a freestanding ASC wants to perform these, they still have to meet coverage. No question. It has to be medically necessary, have to meet coverage, but they don't have to go through the hoops. Information from the MAC. I think that this is an attempt to move site of service to a different site if the physicians don't have to jump through the hoops. But from a coverage perspective, the criteria should be the same regardless of the setting. So that's why a lot of people commented to CMS and say, if this is really a question of coverage, wouldn't you have the same process be applicable to any setting that can perform these procedures? And they basically just said, well, we're using the authority of unnecessary increase in outpatient hospital services as our basis for this program, and that doesn't apply in the other settings, so we're not going to have the program in the other setting.
I agree with your motive, by the way, Valerie.
Okay.
I think you're right about what's ultimately the plan here. In fact, we've seen it in the commercial payer environment where we're now getting site of service medical necessity policies from some of the big bands. Although, when I think about prior auth for Medicare, me and a number of my clients are not all that dissatisfied with the idea of maybe avoiding a denial. Are you having a similar feeling on some of these things, or you think you're still going to get the same amount of denials even after you got a prior auth?
No, I'm not concerned that they're going to be the same amount of denials. What I'm trying to emphasize is that hospitals really should have been doing this all along. You have to have a hardwired procedure to do what I call a pre-service coverage analysis on anything that has coverage restrictions to it. No longer can a hospital afford to assume that just because a physician schedules it, that they've adequately documented and determined medical necessity under the different payer coverage rules or Medicare coverage rules in this instance, such that it will be defensible after the claim is paid. That's where the RACs are making all their money. They're going after the hospitals and saying, your chart doesn't show medical necessity, and you went even and tried to get the doctor's chart, and it doesn't prove it either, so we're taking the hospital payment away. And they're still not taking the payment away from the physician. So that's kind of what I'm thinking on this one.
Makes sense. Amy, do we have another poll to kick out there?
Yeah, so our third polling question, it looks like some of you have gotten a head start on that, so that's good, is does your hospital have a process to evaluate Medicare coverage for services that do not have a formal prior authorization requirement? For example, bariatric and hip and knee surgeries. And your options are A, yes, B, no, C, thinking about it, D, we are having a hard enough time with the new Medicare prior authorization program, or E and A. And as a reminder, if you would like to receive CPE credit for today's webcast, you will need to respond to at least 5 of the 6 polling questions.
So just what you were talking about, Valerie.
Exactly. I think that there's no real good models out there. Hospitals do it in pockets. They have to do it with a prior auth program. They may do it with bariatric surgery or hip and knee surgeries because of what they've suffered with denials. But that's a reactive process for the most part. Right. I think they need to put a proactive process in place. And this needs to become the next wave of where hospitals staff and put something up front. And it means working with medical staff so the medical staff know. Because what if the nurse at the hospital looks at all the doctor's documentation and says, it doesn't meet medical necessity. We're going to have to postpone this a little bit longer because you haven't had enough of conservative treatment, or I can't find the documentation of the conservative treatment. That gets into that patient-doctor relationship. It's an issue. Well, I'm very pleased to see 44% of those say they have a good process to evaluate Medicare coverage beyond just these requirements for prior auth. So that's a very positive. We've got very sophisticated folks on the line, I think.
I owe Paul another $10. Because I was thinking the no was going to be a much bigger line.
Yeah.
And you wonder, is it also because of MSP? I've been thinking about that.
Could be. Could be. And so, Larry, I think you're going to pick it up in terms of, is this influencing the location?
Well, sure. And, you know, the fun thing about thinking about hospitals, and going back to, Valerie, your orientation of thinking about it from the insurance component, it's also a facility and location component, which is highly essential for determining how things are covered, what they're paid, and when, and if they're going to be paid at all. And so we thought that this was an interesting graphic, in fact, that talks about the different key locations. And when you're thinking about the outpatient prospective payment system and Medicare outpatient services only, it really gives you a sense of how that location makes a huge difference. So the on-campus provider-based department versus the off-campus provider-based department. Historically, there really wasn't any difference in terms of reimbursement between these two locations. If you met the provider-based rules at 413.65, you could get proper OPPS reimbursement. With the site neutrality changes, obviously, off-campus provider-based departments, at least the new ones for a lot of services and everybody for other services, are now getting materially less reimbursement. In fact, the same sort of reimbursement as what a freestanding setting would receive, a freestanding physician office. It's important to also note that we often think about the 35-mile rule as the absolute cutoff, but there are some narrow bands that are worth remembering where a off-campus facility can still receive provider-based treatment, even if it's more than 35 miles away. Finally, we wanted to make sure that folks are familiar with hospital freestanding facilities, which these days might be a reasonable way to set things up so long as you can meet state licensure and satisfy your folks in the accreditation office. But these are freestanding enterprises that bill as freestanding, not under OPPS. But the sort of among the power user tips is to make sure that you don't also blow your 3-day DRG payment window applications, because when these facilities are wholly owned or wholly operated by the hospital, those services that meet the 3 or 1-day test will get rolled up into the DRG. Now, Valerie, you and I have chatted about the importance of thinking about on-campus lately, haven't we? Do you have any thoughts about that for our listeners?
Yep. So one of the things to think about is, if you look at the graphic in the middle there, the hospital, right? That's the location with inpatient beds. And so the way I like to think about this on and off campus distinction to start with is to put basically a bubble around any location that has inpatient beds. Because what we didn't have on the graphic is, what if there was a remote location hospital that also had inpatient beds, right? So every place with inpatient beds gets what I think of as this bubble around it, defined by, you radiate from the corners 250 yards and draw a circle around it, and everything in that circle is on campus and not subject to any payment reduction. But then off-campus locations are subject to, first of all, if it's a new location, then you're not even payable under OPPS. You have to put that modifier on that means you're paid that 60% reduction based on a site of service physician fee schedule amount, versus if it is an older original off-campus department, now CMS has cherry-picked the most frequent service, the outpatient hospital visit code, and selected that code to decrease payment. And then the other thing we chatted about here is that we don't even have under arrangement locations on here at all, because hospitals are allowed to have diagnostic services in under arrangement locations that aren't subject to any kind of reduction.
Well, and under arrangements is one of those often forgotten Medicare policy benefits that people should be aware of. It's been in the Medicare Act since the beginning of the Medicare program, and it allows hospitals to provide services directly or under arrangements. And an under arrangements vendor is really just some other entity that can deliver a service that the hospital wouldn't ordinarily deliver. I think it's sort of what they had in mind originally. And so long as the patient has no financial liability to that other entity, the hospital can furnish the service to its patient through this under arrangements contract. And the beauty of it is under arrangements doesn't have to be in a provider-based department. So you find yourself in a situation where you have significantly better flexibility. And it's only for diagnostic services. A therapeutic service from a hospital needs to be in a provider-based department to be billed to Medicare Part B. But for diagnostic services, it's a great opportunity, and it allows a lot more flexibility in operation. A couple of the words to the wise on that point, though, are to make sure that you're not trying to use a all under arrangements provider-based department. That's a no-no. The hospital has to be providing some services directly in order to have a location be provider-based, which is important for things like 340B, as well as if you were trying to bill therapeutic services. But I think it's a really great point you make, Valerie. Also on this slide, we didn't add a dedicated emergency department, which is another way of creating new locations which still have the advantage of receiving proper OPPS reimbursement.
And Larry, this is Paul. I think one important item to note when we're talking about diagnostic services, especially during a pandemic, is the often confusing terminology of reference labs versus referral labs, and how that plays into those diagnostic services as well. So just for folks to be mindful of, even beyond primary care and other items, whether it's imaging or lab or otherwise, it can be quicksand when we're talking about all of these different levels.
Yep.
That's an excellent point. So, Valerie, your point is well taken that location is key. A few things have been changed in our lives in the last 10 months. One of which, of course, and we wouldn't be doing justice to this topic without addressing what the COVID-19 waivers and interim final rule have done to permit a variety of new locations to serve as hospital provider-based departments that ordinarily would never meet the provider-based standards. They would never meet the conditions of participation for hospitals, and therefore we've given you here on this slide and the next one the actual slides produced by CMS when they were trying to show the industry what flexibilities they're going to allow to have for hospital beneficiaries. So allowing the hospital outpatient department to include any number of new locations, community facilities, as well as the patient's home. Those of you who have been playing with the hospital at home program, there's really two paths for this. From an outpatient department service, which is really the topic of this discussion, the home can be a hospital outpatient department, and the hospital can get paid under OPPS for those services. And for inpatient services, CMS has now relaxed the rules to allow, even under arrangements, services of routine care to be furnished in a patient's service and allow that patient's home to be considered a hospital department for inpatient hospital services, a tremendous flexibility designed not so much necessarily to move COVID patients out, although I'm familiar with some hospitals that are doing that, but also just to make room in the hospital for other patients, particularly COVID patients and others, to allow the hospital to treat the sickest of them. We will give some additional materials for you in the notes to check on this, but one of the tips here that we'll talk about in a moment is to make sure that as we think about some of these new locations, you don't trip up on some of the site neutrality rules that Valerie and I were and Paul were just chatting about. So I want to move into that topic right away. As Valerie pointed out, much of the payment policy around OPPS has been dramatically shifted by Section 603 of the Bipartisan Budget Act of 2015, and by now this should all be catechism to the 700 or 800 of you on the call today. But, recap for those of you who don't, is as of January 1, 2017, no off-campus outpatient department of a provider could bill under OPPS unless it was a DED, as we discussed, Valerie and I a minute ago, or it was grandfathered. And the non-grandfathered ones got paid under a different methodology, although it looks like OPPS with a massive haircut to me. Didn't apply on campus, as we talked about. So this stuff should all be old hat to those of you who've been in this space. The CMS dug one cut deeper, as you know, and as Valerie mentioned, and added a site neutrality payment reduction for the most common services, the outpatient hospital clinic visit, which was the source of some significant litigation over the last couple of years, where the industry, rightfully I would say, pushed back and said, hey, Congress drew a line in the sand of old versus new. Old, billing before November 2nd, 2015, would not have the haircut. New ones, unless they're a DED or around a remote location, would. And Congress drew those bright lines. CMS decided to extend the line for those other services, and I'm just waiting for services other than GO 463 to get added to the payment reductions. AHA filed a lawsuit and was initially successful at the district court level, though unsuccessful at the Court of Appeals. And so now the question is, will they go all the way to the Supreme Court? I checked. I don't believe that they filed for cert yet, but I'll double check again. The industry had expected, though, that for those 2019 payment cuts, which were actually refunded to you, as you may recall, after the district court case, those payment reductions, that you would probably not have to worry about giving that money back. Well, I'm sorry to darken your day, but just today, CMS announced a change to that payment policy. And so by July 1, 2021, CMS is going to start reprocessing outpatient clinic visit services, even if they were provided in an accepted or grandfathered location, to be paid at the same rate as the non-accepted off-campus locations. So to make sure you heard me correctly on that, CMS has said that for your 2019 payment reductions, which were repaid to you before, when they reprocess those claims, they're going to come and take that money back. And we're still making sense of that. I'm not aware that how many hospitals have reserved for such an eventuality, which is unfortunate, because I think most of them would have reasonably anticipated they could keep that money. I don't know, Valerie and I have chatted about it, and Paul, I don't know if either of you have any comments on that before we move on.
I was surprised. Since the court had ordered them to refund it, even though the district court upheld CMS's appeal on this particular topic, I honestly did not expect, particularly in the middle of the public health emergency where hospitals have had to cancel elective surgery and have all sorts of extraordinary costs, that they would tighten the screws, if you will, by going and recouping the $2019. I think it's just a continuation of this administration's obvious bias, I think, against hospitals is what it has sincerely felt like. That's how I would characterize it.
And I was speaking with Nina Youngstrom at the Report on Medicare Compliance earlier today, and that was exactly my point, too. The industry has got to be whipsawed at this point. They reduced your pay, they paid you back, they're taking it back again. Can you imagine another industry where your single largest business partner is allowed to move that much money in and out of your bank account once you've relied on them paying it appropriately? What a country. So more to learn about this in the coming months. And again, the notice is old. The ink is still wet on it, and it says by July 1, 2021. It doesn't say after July 1, 2021. So I don't know exactly when that might start. Perhaps if somebody else knows, they can enter that information in the chat window. We can provide some additional information on it. So let me move on to an important new topic as well as an important old topic, and that topic is relocation. So under the payment cuts of Section 603, if a grandfathered facility relocates or expands beyond its footprint, it can blow its exception and no longer get the benefits of full OPPS reimbursement. And the industry has been struggling for some time in determining what exactly does it mean to be relocated or expanded. The guidance we've received from CMS so far is that the location that's on your 855A in the PCOS system down to the suite number is the the four walls of your department. And if you move beyond that, that's when you have relocated it. So we've struggled with what kinds of reconfigurations of space for use of space might be okay, moving walls and stuff like that. But we've managed to think about those things in terms of recycling provider-based sites. That means you can use a grandfathered site to do a new scope of service, which might actually make a lot of sense in the context of the site neutrality rules, which seem to be here to stay, because you might choose to put more high-end services at those locations. And many people think that the old same clinical family of services rule should still apply. It doesn't really. But the thing that's special here now is that in the post-pandemic environment, being smart on your relocation rules is very important, because in the old rules, the general rules, you could have an extraordinary circumstance relocation, which is like an earthquake, a volcano erupting, or an alien attack. But it's pretty narrow, and you've got to request it within 30 days of the date of this terrible event. You have to describe it, and you could be rejected. And I don't know, I can't think of many providers that have used this model yet. Maybe Valerie or Paul have some that have used it. I've heard of a couple. What's special about this rule, though, is CMS is deploying the strategy of thinking about the temporary relocation exception to allow new spaces during the pandemic to be treated as, even if they're off campus, to be treated as if they would have received the grandfathered status under OPPS. This is a really important factor, because if you do it right when you add those new locations, and by do it right, I mean you notify the regional office through their hotline, through their email, that you are relocating a portion of a currently accepted provider-based department, then that location will get good OPPS reimbursement. I think this is a trap for the unwary, because I'm worried that in the haste of moving these locations around, hospitals aren't thinking about this, and they may be in a situation where they've created a new location, and someone will come along later and question whether or not they had done it correctly and whether they were entitled to bill with a modifier PO or not. So I don't know if either Paul or Valerie wanted to comment on this, but to me, this is a critical factor when you're adding new locations for outpatient services.
It is a critical factor, and CMS uses over and over again in the frequently asked questions around this topic. If you want to just expand your departments temporarily to a patient's home for remote services or to another location, you can just expand without notification, and you communicate that on your claims with the modifier PN for provider-based new non-accepted location. And you're going to get paid under physician fee schedule at 60% of the OPPS rate. But if you want to get the OPPS payment rate, you have to follow through this temporary relocation, but then you put modifier PO, and if it turns out to be a remote outpatient hospital visit, you're still going to get the 60% payment reduction that we talked about before. And then what is most confusing to hospitals, and I can't emphasize this enough, folks are getting this very much confused with the telehealth benefit, because they think because the technology is used and the patient's in their home, that to them is telehealth. But no. What makes it telehealth is the location of the clinician. If the clinician's in the hospital and it's an expanded or relocated department in the patient's home and technology is used, that is not telehealth. That is an outpatient hospital visit. It's dependent on the location of the clinician. So as I like to say, or a colleague of mine said, if the clinician's at their home or in the McDonald's parking lot using the technology to the patient in their home, and the home is a temporary, either expanded or relocated area, that's when it's telehealth. If your heads are spinning, you're not alone. This is very complex to understand, and it really is going to play out in the audits that Larry's alluding to and in the cost report that Paul will be talking about.
I also want to note that unlike the current policy for temporary relocations, which had to be done within 30 days of the alien attack, you are allowed 120 days to make your notice with the RO. And if you think you've gotten your RO notice wrong, I think you can correct it and indicate which department had really relocated to this new location, that is an accepted one or an on-campus one, because you're allowed to relocate part of an accepted location, so you can spin that over there. There are some other little weird details in the policies describing this relocation rule, including one that I think goes against the general policy that CMS has about clinical families of services. I find that they seem to be baking a bit of the old clinical family of services rule into the relocation during the pandemic, which is probably they shouldn't have done that, but since they did, it's worth ticking and tying to make sure that when you expand a location into one of these new settings, you expand the same type of location as the new services will be. Paul or Valerie, any comments on this before we move on? Because I think we're coming up on our next polling question. Okay.
Not so far, Larry. I think we're gonna. Yeah, I think we're going to be weaving in and out of a number of these areas, and we've got some great questions from the audience that we can address as part of this as well.
Should we ask Amy to do our next poll?
That would be great.
All right. So our fourth polling question is, does your hospital or health system routinely review and assess locations for services and whether those services are provided in the optimal physical or clinical location? And your options are A, yes, B, no, C, we will now, or D and A. And for those of you that would like a copy of today's slides, you can download them from the folder that says slide deck and handout. We will be sending the slides via email tomorrow along with a copy of the webcast recording.
And this is a great question. You know, we have a few clients who are looking at this from a compliance perspective, but the way Moss Adams has styled this question today, it's really looking at sort of optimization of the service, which is a very positive way of focusing on it.
It is, and one of the slides mentioned it, but we could talk about it here. I mean, a lot of times what I like to now call precious on-campus grandfathered space is being used, for example, for outpatient rehab, when outpatient rehab is a service that isn't paid under OPPS and can pretty much be located anywhere. So, you know, it really does benefit the organization to do this review, and it's like a big shuffling of the puzzle pieces, but you can really have positive impact your bottom line by doing so.
Well, and during the pandemic, we have hundreds of employees working at home. Their offices on campus are empty. Why the heck aren't we doing clinical services in these spaces and let these people either stay working at home or move them into, you know, Class B office space out by the freeway? Don't waste our precious on-campus space. I like your term. It's right on. Did I interrupt, Paul?
No, and I think this is great, and it's so great to see this strong yes answer. In one of our previous executive series presentations as part of our Moss Adams Healthcare Conference this year, one of the items that I brought up was if we reverse back to March, April of this year, when the government and states were saying we need to shut this down, we cannot, you know, folks are having to make a decision about you can't have elective surgeries or we need to discontinue these certain items. The one thing that we noticed was that either federal or state governments were not asking the providers, can you do this safely? Do you have a clinical pathway to administer primary care services by using certain clinical protocols? And we think that that's going to be an area going forward that's going to be critical. Make the providers a collaborative partner in this process. Don't dictate how they should provide care. Ask them innovative ways of how they can achieve this in whatever constraints we have.
Yeah,
Before we move on to the next,
right.
I'm sorry, I interrupted you, Val, but I was just going to say before we
go ahead.
Before we move on to the next topic, I want to make sure that we respond to some of the questions in the Q&A field. One of them is a good one: is the recoupment going to apply only to the E&M charge, the Rev Code 510, or will it apply to all services in the accepted off-campus location? I believe it's only going to apply to the outpatient clinic visit services. That would be my expectation.
Yep.
Certainly
yep.
Hope so.
The GO 463 with modifier PO.
Right.
Yep.
That's right.
Yeah.
We'll sue them
and
again.
one of the other and one of the other questions that our attendees had, they emphasized just how confusing the 2-midnight rule can be, especially with OPPS services. And so often, Larry, as you mentioned up with the skilled nursing facility admit coming out of an acute discharge, family members can come and visit their person in the hospital. They're in a bed, they're on telemetry, they're receiving meals, and then they get discharged, and there's all kinds of surprises. And that's where, especially on the acute side, we continually emphasize, look at those discharge planning procedures. What is that transparent communication that the discharge planning folks are having with the family or with the primary care, just so everyone's in the loop as to what level of care was provided, what setting they're being discharged to, just so that everyone can understand how that works. Because certainly with the patient-driven payment model in the skilled nursing facility setting, having the skilled nursing facility understand surgical procedures, comorbidities, any of those items that have come up in the acute setting so that they can set themselves up for success as they help folks get better on the post-acute side as well.
Yeah.
I'm glad you mentioned the go ahead.
Oh, I was just going to pick up the home
Sorry.
infusion, so you go ahead and respond, Larry.
Well, I was really just going to, I'm glad, that's great, thank you for doing that, but I was just going to mention that Paul's comment about people being able to visit during the stay. I didn't realize how that was going to be one of the factors that plays into the hospital at home program. We have a number of clients that are using the Medicare hospital at home program for all the right reasons in the context of the pandemic. My mother's in a hospital right now, and we can't visit her. If she was in a hospital at home program, that would be just a nice thing to have. And I hadn't even thought of it until you mentioned that, Paul, just a minute ago.
Mm-hmm. Mm-hmm. And then I'm picking up, we have a question here. We have a local home infusion therapy provider, and they want to know if this can be under arrangement as a partner to deliver COVID-related therapies. Well, yes, but there is a whole section in the interim final rules that for coronavirus, therapeutic services can be rendered with under arrangements in one of these either expanded or relocated areas that Larry just went through. But that's a little different than what we were referencing with talking about on a permanent basis outside the public health emergency for hospitals to consider under arrangement for outpatient diagnostic services. So I want to be sure we're keeping those two things separate. But yes, that is an option, but it is for purposes of the public health emergency only.
That's a really important point. And our clients have asked us a lot when the public health emergency is going to end, and your guess is as good as mine. I suspect now that with the new administration that they'll be more inclined to retain the PHE for longer to protect the community. There'll be less of a political aspect to the PHE. Certainly some state governors still have hostility to the public health emergency declaration, but that's a piece that we have been struggling with too. Everybody wants to know. I wish I did. Let me wrap up with some of the key takeaways that are worth knowing in the context of these new locations. You can get proper OPPS reimbursement during the public health emergency, but you've got to do it right with the notifications that are in the rules. The materials are in your readings. So with that, let's move on to our next topic and keep us moving along. Paul, on cost finding and rate setting.
Perfect. Thank you, Larry, and thank you both. Such a great, important dialogue this morning on all of these different areas. You know, when we talk about cost finding and rate setting, and we're talking about all of the areas that Larry and Valerie are mentioning, remember that your Medicare cost report at the end of the day is nothing more of an aggregation of all of the claims activity and patient care that you've provided during a certain period of time. If your revenue cycle, if your HIM, if all of these processes in the hospital are not working as intended, the cost report's a moot point. The cost report was designed to determine Medicare's share of the cost that's incurred to care for all of your patients. So if your hospital spent $100 million this year to care for your entire patient population all in, what portion of that was related to Medicare beneficiaries so that the Medicare program can reimburse you for the resources used? And so what we wanted to talk about in the middle of this presentation is really reminding folks what the cost report itself is trying to achieve, how that plays into payment rates, and ultimately, are those payment rates representative of what it took to care for your patients? So as we're talking about APCs in regard to OPPS, with this ambulatory payment classification, similar to the DRG or the PDPM or the home health or any of these other items, what it's intended to measure is resource consumption. We're taking a base payment rate multiplied by a factor of something that's intended to understand and estimate cost on a prospective basis using historical cost measures. And how CMS calibrates and tries to measure that are these items we mentioned at the bottom of the slide. They're looking at changes in medical practice. They're looking at changes in technology. They're looking at items where it's obsolete or other changes in both clinical operations as well as hospital operations. They're wanting to understand what the new cost data looks like. Oftentimes when we talk about our base Medicare importance presentation, we remind folks of how the market baskets are developed for Medicare services. Medicare uses what's known as a Laspers type market basket, and the Laspers type market basket just measures a basket of goods and services over a period of time, similar to a consumer price index. Medicare wants to know, is it costing more, is it costing less, and what are the factors that are feeding into that? And then the last piece, and this is where Valerie, in her role, the outpatient payment panel recommendations. Not only the payment panel, but comments through rulemaking. Medicare only knows the story that individuals are telling through their cost report or by being vocal about what's actually going out in the patient care community. So just to set the stage for some of those areas that we're going to talk about, where all of the information that Valerie and Larry have mentioned up to this point are feeding into how cash flow is actually coming back to you and hitting the bank. Regarding this market basket update and conversion factors, outpatient recalibrates on January 1st each year, where for inpatient DRG, we're on October 1st. So starting Jan 1, we are now at just about $82.80 for the base conversion factor for APCs. That is 2.4% higher than it was last year. Obviously changes for those folks who are not either submitting quality data or are meaningful users of EHR. But as we note here at the bottom of the slide, the 2% sequestration is still off the table. Originally, it was going to go from May 1 to December 31st. From what we've seen right now, we're extended to the end of March, and it'll be interesting to see with the new administration if there's additional flexibility with that going forward. The 2% sequestration reduction for many of the hospitals that I work with, this is millions of dollars back in the pockets of providers. So it's good to see that in the midst of all of this, that there is that additional 2% coming back. Just as a reminder for individuals on the phone, oftentimes folks will say, well, it's the cost report. All I'm really worried about is DISH. All I'm really worried about is IME, GME, or bad debts, or these types of items. Your Medicare cost report is a treasure trove of information, and that information is used by CMS for any number of areas. It is their source of truth to understand what the resource consumption looks like, and for every dollar that is billed, how much an expense is needed to generate that dollar of revenue. It calculates length of stay. It calculates average per diem costs for routine services. So Medicare takes those cost reports very seriously, and in conjunction with MedPAR data, uses that to determine those resource determinations for DRG and APC payments. So as you can see, this is a helpful table from the OPPS fact sheet, but it just shows you we have our conversion factor, we have our relative weighting, we break this between labor and non-labor, and then we add or subtract certain factors from there. But all along that cycle of determining what the ultimate APC payment will be, there's cost report data, there's market basket data, there's all of these factors that play into this. So when you file your cost report, you are getting that opportunity along with the other 3,000 plus hospitals nationwide to reset and tell the new story of what's actually going on out in the marketplace. This is an important reminder, and it's a little small, but I wanted to remind everyone on the phone. The interesting thing is the difference between DRG and APC rate setting is that on the DRG side, all of the lines on the cost report are consolidated down into 19 common cost centers that are then used along with ICD-10 and other information to then determine what those DRG weights will be. Therefore, if there's anomalies in the data or some providers are higher, some providers are lower, because of the way that the DRGs are consolidated into the 19 common cost centers, it eliminates the intensity of changes year to year. The important thing to remember, though, with APCs is that when they do the APC rate setting, they literally are multiplying straight across. And where we saw this most intensely, and Valerie and I have talked about this for a number of years, is when they made the change to break out CT and MRI out of the other imaging modalities. We saw a massive change in the payment rates for imaging and other APCs because of that sensitivity to rate setting. And why I mention this is that when you're developing your cost centers on your cost report, there are very specific prescribed cost centers with not only cost report lines, but cost center codes. And those codes are used by CMS in order to correlate the line items on the cost report with the revenue codes from the MedPAR data in order to capture the correct APC weighting. So all along the food chain of the cost report and rate setting, you have to make sure that as a provider community, you're working in unison to make sure that you're following those prescribed cost centers with your PS&R information and all of that, because that's ultimately what's going to determine whether or not those resource measures are appropriately stated. One item I wanted to mention along with this is that there is confusion in the provider community or others around the difference in terminology between packaging and bundling. And that's where these items come into play. And Valerie, I'd love to get your input on this because it has to do with two sides of an equation. You package certain items and bundle certain items, and I'd love for you to tell the audience more about that.
Yep. So packaging is a payment concept, okay? So this just means that the payer is saying that they're going to put payment on one line item, but they expect that you're going to break out your charges for the associated services that go with the main item. So for example, if you have a surgery procedure, you're likely to have charges for the surgical suite, but you've of course got medical surgical supplies, you may have some drugs, there may be diagnostic testing that patient gets on the day of surgery. By HIPAA transaction sets, you must represent all of those charges following revenue codes and for outpatients, CPT coding rules. All the charges have to be there. It's just that the payment that comes back may be only on the line item of the claim that has the surgical CPT code. But the payment for the lab, the associated drugs, the supplies are all packaged into that APC payment rate for the surgical procedure. The concept of bundling is completely different, and this is where providers tend to look at the payment rates and they go, oh, there's no separate payment rate for this. Medicare has a status indicator of N, meaning no separate payment. Yeah, it has a CPT code, but no separate payment. Maybe we ought not to charge for that anymore. And so they stop charging, particularly if they are hitting edits with that particular code. Well, edits are related to, are you correctly coding or not? That's a different question than the question of, should I report a charge, right? Or should I bundle that charge into a different line item or different procedure charge on the claim? And we consistently find that hospitals respond to their, what I will call, lack of understanding of claim edits, as well as persistent issues by rolling the charges, or worse, contractually adjusting them off before you bill. If you contractually adjust off things before you bill, you've just made Medicare so happy because you're just making that service cheaper and cheaper and cheaper all the time, which means the APC payment rates go down in rate setting. So bundling is really, you should always report your charges when appropriate, particularly when it's following CPT and other code set requirements, and you only roll them when it is absolutely necessary. And that's going to be pretty much few and far between.
Very good. Thank you so much, Valerie. That just such an important concept for all of our attendees to revisit. And with that, Amy, we'll move to our next polling question.
All right, thank you. So our fifth polling question, does your hospital or health system routinely review CMS's rulemaking and provide comments or feedback to CMS or a lobbying body? And your options are A, yes, B, no, C, unsure, or D, NA. And once you have completed all CPE requirements, you will be able to download a PDF of your certificate from the CPE progress window.
95% for A this time, Paul?
I would love that. That would make me so happy, and I'm glad you mentioned that, Larry, because this is such a critically important item. The providers have a voice. And it's an opportunity for them to collaborate with CMS and really make sure that everyone understands the impact of certain items that are going on. It doesn't have to be combative. It can be collaborative. But using those comment and periods is very important. So absolutely.
Yep. And it's easy now. And so for those that feel strongly on a topic, to be frank, you don't even have to go through a formal hospital approval process. You and whatever your role is can just get on and a simple comment electronically that speaks to, you know, I'm in registration and I have this issue, or I'm in revenue integrity and I have this issue in response to the policies. And it's really important that they get that grassroots input.
I've enjoyed the COVID stakeholder calls for very topics just like that, to really be able to have a back and forth on a particular issue. I think they've been great.
Yeah. All right. Well, this is pretty good.
Better than half. For all of you who are in the no or unsure categories, I'd like to just mention that if you're ever wondering whether or not you can provide feedback, or if you need to find an avenue to provide feedback, Larry, Valerie, and I would always be happy to help you make sure that your comment gets to the right spot. So thank you so much for responding to that. These next couple of slides. Yes, please.
A quick answer to a question, because it's about what we were just talking about. Would that be okay?
Please.
We had a question. Yeah, we had a question about reporting recovery time. Okay, so this is a misunderstood concept, and it gets back to that bundling of charges, right? There is no rule that says X many hours of recovery are built into your procedure surgery charge. There's no rule that says you can only bill a recovery revenue code only when recovery is occurring in the separate department of the post-anesthesia care unit versus from in a room up on your routine floor. Recovery is recovery. And so as long as you have policies and procedures and track it appropriately, then recovery, whether it's in the PACU or up on a nursing floor or even in an area that is next to your cath lab or a diagnostic area, if you're recovering a patient and your policies and procedures say that you consistently apply that charge in that circumstance to all patients consistently, whether inpatient or outpatient, you can bill that under Revenue Code 710. And it's not included in the procedure charge. It's part of your charge structure. And it's appropriate reporting of resources, because some patients use up more recovery time than others. So it's reflecting the acuity or level of care. So I just wanted to respond to that.
Thank you, Valerie. Yeah, it's absolutely critical. These next couple of slides I'm going to go through fairly quickly because Valerie has some very important items to cover as we close out. But we really wanted to center on a very interesting concept that's been occurring over a period of time and make individuals aware of the impact that the cost report has on rate setting and other items. As I mentioned before, these cost to charge ratios were taken from the IPPS final rules. But just to give you a sense, for these 19 common cost centers, over the last 5 years, for these various services, there is a trend that's occurring, and we are trying to understand where that trend is coming from. So as you can see, these are the 19 common cost centers here. These are the general cost report lines and the revenue codes that typically feed into that. But I want to show you a graph that's very indicative of what we're seeing. These cost to charge ratios are going down, and they're going down each year in many cases. What this is telling the program is for every dollar of revenue you bill on the facility side, it's costing you less and less to generate that dollar of revenue. The concern with this is it runs counter to most of the conversations that I have with acute providers nationwide. There are a couple of things that could be feeding into this trend. The first one is many providers nationwide have gone through some type of major cost containment or reduction in force, cost overhaul, whatever term or process you want to put on it, they're trying to find ways to bend the cost curve. Many providers, conversely, have also gone through ChargeMaster or other pricing changes. They're increasing charges. They're trying to level set charges in relation to the marketplace. All appropriate business procedures. But with that being said, everything that's going on in terms of pricing changes or cost containment or cost shift, any of those different areas, what we want to remind everyone on the phone is, regardless of what's happening strategically or operationally, make sure that there's not an unintended consequence in the cost report when you put those numbers in. And let's talk about cost centers and general ledger departments. Cost centers can include more than one department. Now, it is the case where one department can be a standalone cost center, but oftentimes, especially in the overhead areas, if you have administrative and general or certain areas, you may have multiple departments on one line that end up getting stepped down. When you get down to the patient care areas, though, there is often the case where the department itself can stand on its own as a cost center. And then we have to be conscious of those costs that the program is not paying for through the cost report. Items like physician compensation, if you have employed or contracted docs, we're going to be removing those compensation items for contract labor, salaries, and benefits. We're removing those off via A82, and we're taking the pro fee charges off of Worksheet C to make sure that the cost to charge ratio is still only for the technical component. Or we look at items where we have to move costs and charges between cost centers. But at the end of the day, what we don't want to have happen is we don't want to have overhead from the hospital go to areas that aren't using that overhead. Or maybe there is a different way to report our physician compensation when we're talking about the difference between provider-based and freestanding. We want to make sure that we're not allocating overhead to areas that either are not using it, or maybe there's a different mechanism to report those costs or charges through. So one thing we just wanted to reemphasize is the definition of a cost center, understanding what the fundamental and functional purpose is of a cost center, and that if you look at that line item, whether it's radiology or laboratory or emergency department or otherwise, that it can stand on its own. When you look at that cost to charge ratio of 0.27, it's representative that you build this number of charges and you incurred this amount of cost, and that's actually what it took for that cost center to stand on its own. But another important area, and this goes back to what Larry and Valerie have mentioned before, is understanding when we're talking about provider-based. Say we're talking about a provider-based clinic on line 90. The technical portion being billed on a UB04 hospital claim form, those professional services, unless you're method 2, being on a 1500, looking at where those costs and charges are reported on those line items if they've met the provider-based attestation rules. Potential eligibility for the 340B program, understanding how those professional expenses and charges are removed, and then understanding how all of this feeds into rate setting. For instance, one of the items that we wanted to cover is that when you report physicians' private offices or physicians' practices below the line in those non-reimbursable cost centers, one of the interesting things about that is you don't remove costs from non-reimbursable cost centers. So if you have a physician practice where you're reporting a medical group or some other item below the line, make sure that you understand the nature of the medical group, how it's being reported, because all expenses are going to absorb other expenses through the step-down allocation. So everybody can do it a little bit differently. You have to follow the provider reimbursement manual. You have to follow the cost report instructions, but just make sure for your unique organizational and operational situation that everything's being reported where it should, because if you have items that are in non-reimbursable cost centers or in other areas that may not use that overhead, or it's not all representative, you're pulling overhead away from the hospital departments that is then affecting the amount of cost divided by charge to tell the Medicare program what those resource uses look like. So we didn't want to provide any definitive conclusion or say you should do it this way or this way, because everyone's situation is a little unique, but just make you aware that what we're seeing in the rate setting data is there are factors at play in the cost report that could be unintentionally affecting rate setting or other items, and just making sure that everyone understands that year to year things can change. You're revisiting how your medical group or your ancillary departments or your provider-based departments, are they in the proper location? Are we reporting them correctly? Are we marrying up the charges on the PSNR with the right location for where those services were provided? All of those factors will play into just optimal rate setting. It may still be that the amount of cash flow from the federal government continues to go down. We just want to make sure that it's going down appropriately with how folks' cost data is being reported. So a lot of information right in the middle of this, but just an important key concept that the cost report at the end of the day is an aggregation tool of all of the things that Larry and Valerie have mentioned, and we just want to make sure that everyone's setting themselves up for success through that. So with that, Valerie, I will take a breath and pass it over to you to cover some of these critically important items from the rule itself.
Thanks, Paul. Wow, that's a lot. And I'll even try to associate some of what you just spoke about when I'm drilling down a bit more and talking about some of these key topics that are important to understand. So I mentioned earlier when Larry was talking and we were talking about locations that in this world of the public health emergency, you absolutely have to understand what Medicare's definition of telehealth is. And it's confusing. And telehealth, as defined by Medicare, is bound by statutory constraints. So even before the public health emergency, back in 2019, CMS was very forward-thinking in this regard and said we have to start moving into the 21st century, modernizing Medicare. And so we're going to be very intentional with defining other services that are dependent or use technology, telecommunication systems, but do not meet the narrow definition of telehealth. And therefore, these remote technology-enabled services can be delivered to any Medicare beneficiary, not restricted by geographic location, can be rendered when patients are in their homes, and these can be either rendered by physician practices that are freestanding or by clinics and departments of hospitals that are, of course, when the services are ordered. Because as I also like to say, hospitals are passive, right? Cannot do anything without a treating practitioner's valid order, or at least there's very few things you can do without the valid order. So a couple of the services that fall in this camp are what are called virtual visits or electronic visits. Same kind of telecommunication technology you think of with telehealth, but these are different and they have unique codes. Another concept is remote physiological monitoring. Now, when Larry talked about hospitals without walls, of course, to render that kind of inpatient care to patients in their homes, remote physiological monitoring is a key component to it. But remember, that patient's admitted as an inpatient, right? Admitted as an inpatient. What we're talking about here is outpatient hospital departments who are rendering various remote physiological monitoring services. Always billable. This is not bound by any of the restrictions of telehealth. So on this slide, I give you some of the HCPCS codes and or CPT codes that apply. So virtual services are defined by CMS with HCPCS level 2 codes. For 2021, beginning January 1st, they differentiated the G2010 and G2012 to be used by physicians with evaluation and management in their scope. So think about those as physicians and non-physician practitioners such as physician assistants and nurse practitioners. But other clinicians can do these virtual services, including therapists, licensed clinical social workers, nutritionists. Now remember, when those qualified health professionals are billing Medicare benefits, they are restricted to the benefits that apply to those types of professionals. So for licensed clinical social workers, for example, it's outpatient behavioral health. That's all the kinds of patients and services they can bill for, but they can do it virtually and bill these codes. They can also do e-visits, and there is a set of codes for qualified healthcare professionals separate from clinicians with E&M. Now, it's important to note that there are unique CPT codes for phone-only visits. However, Medicare has said already in the physician fee schedule rule that that will not continue to be covered after the public health emergency. So right now, phone-only is only covered during the period of the public health emergency. What if these clinician or other provider types are employed by the hospital and the hospital is billing for them on the uniform bill? Well, the outpatient prospective payment system says that if you bill this, you're billing it for a qualified healthcare professional that you employ for a covered benefit, and we're going to pay you under the physician fee schedule, but we're paying the hospital. So just there, that's exactly what happens with therapy services. That's what's happening with these other services as well. So here I have a comparison of about certain codes that apply to remote physiological monitoring. Now, these aren't all the CPT codes that apply, but this is a particular set of codes that CMS took a lot of time in the physician fee schedule rule and stepped through. You start remote physiological monitoring with this code, then it's every 30-day code. These parts are only billable or ordered and partially performed by clinicians with E&M in their scope. These others are by staff only, so they're practice expense only codes. So many of us commented to CMS and said, wait, when we look under the outpatient prospective payment system, the status indicators are all over the map. Some of these codes you have assigned APCs and paid. Other you say the hospital can't bill at all. It doesn't seem like there's any rhyme or reason to this. And CMS seems to conveniently have amnesia when it comes to understanding that outpatient hospital departments are performing the exact same services that can be performed in a freestanding physician practice, right? And I think their amnesia has grown this last year with this particular bent that the administration has. So when you look at this class of services, it is confusing. But yet here you have staff supporting your clinicians in your outpatient departments. And so what do you bill? So CMS, unfortunately, didn't change anything in the final rule, but they did say, you've raised some good questions. I think we're going to have to go back to the drawing board. And so I think this is a place where advocacy is going to be needed. People need to submit comments, maybe some case examples. They need to understand how this happens in a hospital setting so that they can get the payment system set up right. All right, I'm turning now to new technology. So I hope you all are very familiar with the inpatient prospective payment system, new technology add-on payment. Very, very dependent not only on your correct coding when you utilize one of those new technologies, but also your pricing. Well, the same is true for outpatient devices that have the temporary pass-through status. 7 continue from last year through 2021, and they've added 3 new ones. And I've sorted here the correct status indicator to understand which of these devices are is H. You have to go to the rule to know exactly what manufacturer's device qualifies for using one of the applicable HCPCS codes, C codes, that then will get paid the pass-through payment. Pass-through payment is fundamentally dependent on your price. Remember, Medicare takes the line item charge with the HCPCS code for the device on your claim and multiplies it by your implantable device cost-to-charge ratio, and they think that's the actual cost, inclusive of handling and overhead, that that device represents. I guarantee you that most of you all don't use your cost-to-charge ratio as your basis for pricing, but you ought to. And in the inpatient prospective payment system rule this year, they said twice there's nothing to preclude a hospital from using the cost-to-charge ratio for purposes of correct pricing, because this is how CMS does the rate setting. And this is how you get paid a separate additional amount for 2 years to 3 years, depending on the time frame that they've approved for the device. And then they use that information to then bake the calculated cost into future APC payment rates. So we all collectively have ourselves to point fingers to if we wind up with future payment rates that don't even cover the cost of the device because we have failed to price it properly. I just say, who cares about price transparency? Because no patient's going to look at it. You might have to have a good pitch to the media that might look at it, but they need to understand your prices have to be driven by Medicare's payment policy and rate setting policy. It's so critical.
Yeah, the key individuals who are interested in pricing transparency are health plans, not patients.
Exactly. So, Amy, I think we have our next polling question here.
Yeah, so our last polling question is, are you aware if your hospital lab must submit clinical lab negotiated rates by payer and test volume in the first quarter of 2022? And your options are below. Select the answer you choose and hit submit. And I'll use this time to remind you that if you did attend today's presentation in a group and would like to receive CPE credit, you must complete the group attendance sheet found in your console.
Yep. So this is really important, and we have a few more slides to cover about lab in particular. We also have a couple on CAR-T. So I know we're reaching the end, so we'll be clear. But lab, Paul mentioned this. It's critically important that you understand if you're getting specimens submitted to your hospital lab for testing. In that instance, your lab is a reference lab. Conversely, you may take specimens from your outpatients and inpatients, and you may need to send them out to an outside lab to perform the services. In that instance, the outside lab is a reference lab to you, but because it's your registered hospital, inpatient, outpatient, you have to put that lab test on your claim. So many of you don't know. So this is critically important, and I'll touch upon this in a few minutes, what the reporting requirements are. Oops, I went a little bit too fast. So quickly, for any of you who perform stem cell transplants, who gets cost-based reimbursement anymore? Well, the answer is you do now for the donor search and cell acquisition cost. They've already released draft cost report changes to not only capture direct purchased expense in Cost Center 77, which has existed since 2017, but now a new worksheet D6 to calculate the services that you render to the donors, potential donors that you work up until you identify a match. One of the most complex areas in Medicare, and so if you perform these services, I can't emphasize enough that you probably need both a revenue cycle and cost report review around this to make sure you get every legitimate dollar back in actual cost reimbursement here. CAR-T, many stem cell transplant programs also perform chimeric antigen T-cell therapy. These are the first products of a patient's genetically engineered cells that, when reinfused back to the patient, act like little Pac-Mans and eat up the cancer. It really is the future of potential eradicating cancer. There are complex issues here. So this can be performed either inpatient or outpatient, but the payment methodology is very different. But CMS did create a new DRG 18 that went into effect last October. But again, if you're not pricing your charges properly, you will not even cover the cost of the product. And the ASP plus 6% payment on the outpatient basis not just covers the product, but any associated patient care costs to collect the cells and to process the cells. So I'm going to leave you with a couple of slides on the laboratory. And this is where, if you look at the references here, you will understand and learn if your lab performs enough reference testing on specimens that you're going to have to report your negotiated payer rates through a portal that CMS is going to open now the first quarter of 2022, but your data to report is based on the first 6 months of 2019. So Paul, I think you have a couple of slides. I know we're just tad going over here.
Yes, I think, there we go, perfect. We just wanted to mention to all of you, we've got a couple of really important webcasts coming up just to continue our education. The first one coming up on February 2nd, Navigating Contracting Amid Healthcare Fraud Regulations. Larry, I believe you'll be joining us again for that one.
That's right. Looking forward to it.
Which would be
particularly those of you involved with physician contracting, referral source contracting. That's what it's all about.
Absolutely. Yes, and then coming up on the 10th of February, our update on Worksheet S10. Our S10 team has been busy working with contractors nationwide on the S10 audits this last go-around, and we'll be sharing best practices and takeaways from those audits. Critically important to make sure you're setting yourselves up for success on your distribution from the UC pool. Please check out our content hub, as well as Larry and the Foley's team of healthcare law blog. So tons of great resources out there. I know we're 2 minutes over. I can't thank all of you enough for spending time with us this morning. A tremendous amount of information in 90 minutes. And as always, Larry and Valerie, thank you so much for your subject matter expertise in these areas. It only helps to help everyone just make sure that they're getting the cash they need to provide the best care possible.
Thanks for including us.
And with that, Amy, we'll send it back to you to close out with our survey.
All right, thank you. And thank you, Valerie, Larry, and Paul, for a great presentation today. If we didn't have time to answer your questions, we will do our best to follow up with you after the webcast. And if you met all CPE requirements, your certificate is available to download now in the CPE progress window. I will keep the webcast console open for a few minutes to give you time to download. A copy will be emailed within 3 weeks should you have any difficulty downloading it now. And here is a link to an online survey where you can provide feedback for today's presentation. Please take a moment to complete this survey, as your feedback is very important to us. Thank you for joining our webcast. We hope you'll join us again next time.